హలో నవీన్ స్టార్ట్ చేస్తున్నామా?
హలో సార్.
నవీన్ స్టార్ట్ చేసేద్దామా?
స్టార్ట్ చేద్దాం సార్.
ఓకే, జస్ట్ యూ ఇంట్రొడ్యూస్ హిమ్ అండ్ స్టార్ట్.
డాక్టర్ సంతోష్.
Yes, sir.
Yeah, please introduce yourself and start the class.
Okay, sir. Good morning to all my seniors. My name is Dr. Santosh Pawan Kumar, and I'm a DNB student, private DNB student in Care Hospitals. Today, I'm going to present a case which is torsion ovarian cyst in a maternal patient. So, initially, I'm going to present the case, then we can discuss about the microstenosis and anesthesia implications in microstenosis. My patient is K. Nagamma, a 31-year-old female resident of Visakhapatnam, studied 8th class and a homemaker, belongs to low socioeconomic status, came to ER with complaints of pain abdomen left side, which is radiating to back since 1 week, bleeding per vagina since last 2 days, and vomiting 4 episodes since 1 day. History of presenting illness, my patient was apparently already 1 week back, and the present complaint started with abdominal pain since 1 week in the left lumbar region and iliac fossa region, which was insidious in onset and gradually progressive in nature initially, and the intensity of the pain suddenly aggravated. So she came with unbearable severe pain in left iliac fossa and lumbar region since last 6 to 8 hours. The pain is radiating back. It is aggravated by movement and physical stress. It was relieved with medications for the last 1 week, but it is not relieving right now. There is no history of pain relief post-pain or food intake. There is no history of cough, shortness of breath, no history of fever, burning, infection, or loose stools. There is a history of nausea and vomiting present for the last 1 day. She had 4 episodes of non-bilious vomiting, which was okay. And she had an episode of bleeding per vagina since last 2 days, which is not quite well, mild to moderate, little spotting on the underpants. Past history, she was a diagnosed case of chronic heart disease with severe MS, severe MR, and severe PR, and severe PAH, pulmonary arterial hypertension. She underwent the percutaneous balloidal mitral valvoplasty 5 years back, and she continued medication for 2 years. Later on, she discontinued medicines for the last 3 years. As of now, she is not taking any medication related to the heart disease. There is no history of hypertension, diabetes, tuberculosis, or bronchial asthma, epilepsy, thyroid, CVS, CAD, CKD, blood transfusion. There is no history of food and drug allergy. Personal history, she consumes mixed diet, and her sleeping pattern and appetite pattern is normal. There are no bowel and bladder alterations. She is a non-smoker and non-alcoholic. Family history, there are no hypertension patients in the family members, and the rest of the family history is not significant. Menstrual history, she attained menarche at the age of 13 years. Previous menstrual history was like she used to have 3 to 4 days of cycle, either with an interval of 28 to 30 days. Her flow is normal and no pain or no flow during the menstrual cycle. Her last menstrual period was on 17th June 2023. Marital life, she non-consent marriage, 17 years. She was married 17 years back, and she had 2 deliveries and tuberculosis 16 years back. General examination. Patient was conscious, coherent, and well-oriented. Her weight is 56 kgs and height is 150 centimeters. There is no evidence of failure, clinical evidence of failure, sinus clubbing, lymphadenopathy, or radial edema. Breast, spine, and thyroid appears to be normal. Her airway examination revealed mouth adequate with a maladaptive grade of 2. Temporomandibular joint is mobile. Thoramental distance is more than 6.5 centimeters. T-spine, cervical spine, flexion, extension, and all rotational movements are normal. There are no rotational restriction of movement, or there is no pain while moving the spine. And her dentation is normal. There are no braces or no caries, no missed tooth, no caps. Vital information, she is a febrile right now. Her pulse rate is 80 beats per minute, regular and normal volume, normal in character, no vessel wall thickness, no radial delay, no femoral delay, all peripheral vessels are solid. The BP is 140 by 90 millimeters of mercury. The respiratory rate is 18 breaths per minute, abdominal thoracic. SpO2 is 98% at room air. Temperature is normal. Her GRBS is 151 milligrams per deciliter and this is 15 by 15. Systemic examination result, CVS. On CVS examination, you can S1, S2 heard, murmur is heard, respiratory bilateral normal that sounds are heard and no murmurs of difference. CNS examination, there will no focal neurological deficits. On parabdominal examination, inspection, abdomen is little distended, umbilicus is midline and everted. No abdominal wall edema or no engorged vein. On palpation, abdomen is soft and there is no guarding or rigidity. Tenderness is felt over the left lumbar and iliac fossa region. There is a cystic mobile mass in the left iliac fossa. No local rise of temperature, no rebound tenderness. On percussion, tympanic node is present all over the abdomen, dull node over the viscera and over the region, and that is in the left iliac fossa region. On auscultation, bowel sounds are heard and no audible UV or venous sound. CVS examination, detailed CVS examination reveal on inspection, chest wall is bilaterally symmetrical, elliptical in nature. Trachea central position, apex rate is seen in the fifth intercostal space, lateral to mid-clavicular line, below and behind ankle. There are no pulsations or engorged veins or such stuff. CVP is normal. On palpation, apical impulse was felt in fifth intercostal space, lateral to mid-clavicular line. Trachea position confirmed, it is centered. There is no deviation to right or left. There is no tenderness of critics over the chest wall. On percussion, right, all hard borders are located. On auscultation, S1, S2 are heard. S1 is muffled and there is a pansexual model present and openings are heard in the mitral area. With this brief history, we came to a differential diagnosis of left ovarian cyst, and ovarian mass may be malignant or benign. Lymphadenopathy can be there, and sigmoid colonic mass or rectal mass can be have to be ruled out through other machines. On further evaluation, all her lab parameters are within normal limits. Her ECG showed sinus rhythm, which is irregular, and there are no significant ST elevations. On 2D evaluation, she found to have a chronic rheumatic heart disease, severe MS, severe MR, mild PH, mild tricuspid regurgitation, good biventricular function, with an EF of 49%, left ventricular EF is 49%, and grade 1 diastolic dysfunction. So we have taken up the case for excision of the left ovarian cyst. So for conducting anesthesia, these are the goals that we have kept for managing the patient. And our main goal is to maintain the heart rate on the lower side because tachycardia will precipitate the left ventricular function and it might lead to atrial fibrillation. So immediate treatment for AF, like if as of now she is not in AF, but if she develops AF during surgery, immediate management of AF to be done. So we have kept our defibrillator ready and all the drugs ready for that. Aortic compression management was our goal, and the remaining goals are maintain adequate preload and afterload to proper functioning of LV, adequate myocardial contractility, and the use of fluids is the paramount of this anesthesia goals. So we have taken up the case into the OT, and this is the procedure that we have done for conducting the test. We have evaluated the patient through pre-anesthesia evaluation, and we have kept an active invasive DT monitoring radial artery connection, and we have placed central venous catheter for better management of fluid. And we have placed an epidural catheter at L1 epidural space, and we have administered injection lignocaine 2% weight by volume and injection ropivacaine 0.7% weight by volume as an initial dose. After 10 minutes, we have achieved a sensory blockade of T8. Later on, we have started injection ropivacaine 0.75 epidural injection and continued in the post-op. Throughout the procedure, we have carefully monitored the hemodynamics and procedure was uneventful. There were no significant hemodynamic changes in during the surgery. In the post-operative period, patients still have the risk of heart failure, still have the risk of pulmonary edema, and if we do not manage the pain or analgesia in adequate manner, she might develop sympathetic flow, and which might trigger the heart rate and all the complications related to the sympathetic flow. So, and for the cardiac status, she was referred to cardiologist for further necessary management. Epidural infusion continued till day 2 of the post-op. So, the pain management. Post-operative managed with IV antibiotics, diuretics, and beta blockers as advised by the cardiologist. And post-op period is also uneventful. She was monitored in ICU for 2 days, and later on she was shifted to ward, and she was kept in the ward for another 3 days. She was discharged on day 5 of with oral patients, which included oral antibiotics and potassium sparing diuretics and beta blockers for beta blockers. Discussion in my responses. So, contents of my presentation will be like this: introduction, etiology, pathophysiology, disease course, clinical presentations, investigations, PMC evaluation, anesthetic management, post-operative care, and special considerations in pregnancy. Introduction: the mitral valve separates the left atrium and ventricle. You can see the picture over here. This is the mitral valve. It is a bicuspid valve with an anterior and posterior leaflet, and each leaflet is divided into A1, A2, A3, and P1, P2, P3. Mitral stenosis is a valvular heart disease characterized by mechanical obstruction of blood flow from left atrium to the left ventricle. Obstruction occurs due to the thickening of valve leaflets, thickening and fusion of chordae tendineae, or mitral annular and punctural calcification. And incidence is as follows: approximately 1 per 1 lakh in developed countries. In India, we have 5.4 per thousand in 1995. In recent studies, it has been reduced domestically, and as of now, the incidence in India is 0.5 to 0.64 per thousand population. Developing countries have higher rates of fever and consequently higher rates of mitral stenosis. The prevalence of mitral stenosis continues to decline as the prevalence of rheumatic fever declines. This is the pictorial depiction of prevalence in various countries. Etiology: rheumatic heart disease is the most common cause for mitral stenosis. Acquired valvular heart disease, especially mitral stenosis. Rheumatic fever is responsible for 40% of the cases. It is an autoimmune reaction following through a beta hemolytic streptococcus infection. Females have a greater tendency to develop mitral stenosis rather than males. And other etiological factors are like degenerative calcific mitral valve disease, rheumatoid arthritis, leukocytosis, Pacemaker disease, sarcoidosis, mucopolysaccharidosis, Whipple's disease, and atrial. Pathophysiology: in this image, we can see the pathogenesis of the mitral stenosis. Initially, it starts with a streptococcal throat infection, sore throat, and most of us might have already experienced sore throat in our lifetime. About 97 to 98% resolve normally, but the remaining 2 to 3% of population develops rheumatic fever, which is again an autoimmune disease. As soon as the bacteria enters into our throat pharyngeal mucosa, our immune system develops antibodies against the beta hemolytic streptococcus bacilli, and these autoantibodies acts on the various other tissues like CNS, skin and subcutaneous tissue, joints, and heart. Because of the molecular mimicry, the membrane cells of our heart or joints resemble the antigens of the bacteria. So that is the reason these antibodies acts on the above mentioned joints, CNS, skin and subcutaneous tissue, and heart. So as of now, we will focus on the heart part. In our As of now, we will concentrate on the heart part. Our heart has pericardium, endocardium, and myocardium. So, if the antigen antibody complex attacks the pericardium, then it causes pericarditis. So, in pericarditis, we have 2 layers in the pericardium, visceral and parietal. So in between the two layers of the pericardium, there will be fibrin deposition due to the leakage of the fibrin from the pericardial uh, epithelium. So because of the inflammation, the vascular permeability increases, which results in fibrin deposition between the pericardium, two layers of the pericardium. So the pericardium, the two layers of the pericardium gets filled with fibrin threads, and which results in pericardial rub on auscultation. But as soon as the acute fever episode subsides, the plasmin and our own defense system resolves all the fibrin threads and the pericardium becomes normal. So there will not be any long-term complications in the pericarditis. And even for the myocardium, we can see inflammatory bodies in the myocardium. Because of this inflammation, the myocardial length will increase, so the dilatation of the heart will be there. So it is called myocarditis. The inflammatory bodies are called Ashoff bodies. Because of these inflammatory reactions, the functioning of the heart decreases and it might lead to sudden death of the patient, or it might resolve spontaneously with the medication. So obviously, even in myocarditis, there will not be any chronic complications after the rheumatic fever. But for endocarditis, there will be chronic complications, because as soon as the immune reaction, immune related inflammation occurs on the endocardium of the heart, there will be erosions in the endocardium, which covers the valvular tissue and even on the even on the heart musculature. So when the tissue gets ruptured on the valvular area, that results in the aggregation of platelets and other clotting factors aggregation uh, over the mitral valve area, which results in fibrin threads, which starts towards the periphery and extends towards the center. But it will not. It will result in healing with fibrosis, but it will not resolve completely. So, with every episode of rheumatic fever, there will be certain limitation in the mitral valve area. The area of the mitral valve get constricted with each and every rheumatic fever episode, because of which, after several episodes of rheumatic fever, patient develops rheumatic fever. Usually, the disease can stay latent up to 20 to 30 years also, but even after 20 to 30 years, they will develop mitral stenosis. This is the pathogenesis of the mitral stenosis due to rheumatic fever. And this is the pictorial depiction of normal mitral valve and the stenosis on the right side. The sequence of pathological changes after a rheumatic insult: thickening of valve leaflets and cusps become rigid, which results in fusion of mitral commissures, which further results in shortening of fusion of caudate tendon, and further results, all the changes leads to funnel shaped or fish mouth valve of fish mouth shape of mitral valve, which further results in calcification, immobilization of the leaflets and narrowing the orbit, which results in altered flow pattern due to deformity, which further results in thrombus formation and arterial embolization, which may occur in the later phase. These are the sequential changes that occurs in the after mitral stenosis. First chamber that gets affected is left ventricle. Mitral stenosis causes obstruction of diastolic inflow, which is prolonged early diastolic mitral inflow and delayed filling, which further results in left ventricular end diastolic pressure and end diastolic volume decreases. It results in the increased LA pressure. Due to increased pressure, the LA chamber itself enlarges, which the pressure transmits to pulmonary arteries and causes pulmonary hypertension, pulmonary congestion, and which might result in mitral fibrillation and also left atrial thrombosis. Because of the left, it is a sequence. It is a vicious loop in which the heart, each and every chamber of the heart gets deteriorated over a period of time. After LA, the next chamber which gets affected is RV. RV pressure overload and RV right ventricular hypertrophy can be seen, and RV failure will be seen. After RV, the last chamber to get affected is A, and RA enlargement will be there. Right as regurgitation, increased GUT, and hepatic condition also there in late stages of the mitral stenosis. LV filling. This is a physiology of the LV filling. LV filling usually occurs in two phases. First one early and the second one is the late. First one, as you can see in the image that is there in the slide, in the early stage of the diastole, about 2/3 of the volume gets filled because of the pressure gradient between the LA and LV. In the second stage, and that is our late stage, the atria gets contracted, that is the atrial systole. Then the remaining blood volume, which is already present in the left atrium, will be transferred to left ventricle, and the remaining filling of the left ventricle happens. So, in the early phase, the isovolumetric relaxation of left ventricle results in the pressure drop in left ventricle. As soon as the mitral valve gets open, there will be a pressure gradient. So, because of this pressure gradient, blood in the left atrium transfers into the left ventricle in the early stage. Later on, during the atrial systole, the remaining volume of the blood that is present on the left atrium gets transferred to left ventricle. This is the normal filling. In case of mitral stenosis, LV contractility and function is usually normal in early stages, but LV dysfunction can occur in later stages. As stenosis worsens, flow restriction limits LV filling and LV preload. In addition, there is an increased afterload due to reflex vasoconstriction in response to the low cardiac output results in vasoconstriction. It is a reflex caused by our own body, autonomic system. LV function occurs due to left LV muscle atrophy as a result of chronic underfilled state. As a result of chronic underfilled state, LV muscle gets atrophied because of less function. There is leftward shift of the interventricular septum due to RV hypertrophy. This is also seen in the later stages of the mitral stenosis. So, mitral stenosis, this is the Jones criteria for diagnosing right aortic stenosis. It contains major criteria and minor criteria. Major criteria is the it contains five entities: carditis, polyarthritis, edema marginata, which is also known as the impedance Sydenham's chorea or Sydenham's chorea, subcutaneous nodules. And minor criteria includes fever, arthralgia, raised VAS, rheumatic fever history, and first degree of heart block. Any two major criteria events or one major plus two minor criteria will be considered as a traumatic fever. Grading of mitral stenosis based on the valvular area. The normal valve size is 6 centimeters. Mild mitral stenosis is when the mitral valve area is between 1.5 to 2.5 centimeters square. Moderate mitral stenosis is 1 to 1.5 centimeters square. Severe mitral stenosis is less than 1 centimeter square. So in mild mitral stenosis, the symptoms will be very minimal and they can be only on exertion or sedation. In moderate mitral stenosis, symptoms will be mild exaggeration, no symptoms at rest. In severe mitral stenosis, symptoms present even at rest. This is another type of grading of MS. One is mitral valve area. The first one is mitral valve area, 1.5 to 2 centimeters square is the mild. Moderate is 1 to 1.5, and severe is less than 1. Severe is less than 1 centimeter square. Another entity is mean transmitral pressure gradient. It is less than 5 millimeters of mercury, then it is called mild mitral stenosis. And if it is less than, if it is 5 to 10 millimeters of mercury, then it is moderate. If the pressure gradient is more than 10 millimeters of mercury, then it is severe. And the third entity is pressure half time. If the half time measured is less than 150 milliseconds, then it is mild. And if the time measured is 50 to 220 milliseconds, and if the time measured is more than 220 milliseconds, then it is severe mitral stenosis. Pulmonary changes. Because of the mitral stenosis, there are some certain pulmonary changes that we can observe, which are of two types. Number one is passive changes and reversible, which occurs in the early stage. And the second one is the irreversible pulmonary arterial hypertension. The passive pulmonary hypertension is because of the elevation of pulmonary venous and capillary pressure, because of passive backward transmission of increased left atrial pressure and no intrinsic abnormality in the PFA. So the vasculature of the lungs will remain the same, but the pressure in left atrium will be transmitted through the vessels, and which results in pulmonary arterial hypertension. It is a passive process, and it is reversible as soon as the left atrial pressure decreases. The pH also comes back to normal in early stages, but in later stages, pH becomes irreversible because as the stenosis versus, there will be reactive changes in the pulmonary arteriolar bed, which results. I'll show the diagram so that we can get a better understanding of this. Arterial constriction and muscle hypertrophy will happen. This leads to progressive obstruction of the blood through to the lungs. Yeah. So in this image, we can see as the mitral valve gets stenosed, there is an elevated left atrial pressure which gets transmitted through pulmonary vein to pulmonary vein, which results in pulmonary venous hypertension, which further results in the passive transmission of LA pressure to the pulmonary bed of the lungs. So here the because of the high pressure, the pulmonary arteries get constricted, vasoconstriction happens, and interstitial edema will be there. This is the one channel of the loop, and the second reactionary is pulmonary vascular changes due to the reaction of the high pressure in the left atrium, which results in pulmonary arterial hypertension, which arterial hypertension, which further results in left ventricular hypertrophy, followed by RV dilatation and pushing of the septum towards the left ventricle. So the RV will be dilated and hypertrophied. LV volume will be decreased and pressure also will be decreased, and which further results in right after regurgitation because of the increased pressure on the right ventricle, which will be transferred to right atrium and further results in congestive heart failure. Pulmonary hypertension, the pressure is, we call it as the pulmonary hypertension if the pressure is more than 20 millimeters of mercury in resting state, or the pressure is more than 30 millimeters of mercury during stress period. Hemodynamic changes during MS. At rest, the left atrial pressure will be normal in mild stages. In moderate disease, the left atrial pressure will be more, and in severe disease, the left atrial pressure will be too high. At rest, the pulmonary arterial pressure will remain normal. In mild disease, will be mildly elevated in moderate disease and will be drastically elevated in severe disease. Cardiac output remains normal in mild state, even in moderate state, but the cardiac output will be reduced in severe disease. After exercise, the left atrial pressure will be raised in mild, will be considerably raised in moderate disease. In severe disease, the patient will not be able to perform any exercise because of severe breathlessness. Pulmonary arterial pressure and the pulmonary arterial pressure will be mildly elevated in mild disease and will considerably elevated in moderate disease. Cardiac output will be increased in both mild and moderate disease. This is the pressure volume loop. As you can see, the loop in the white is the normal for our reference, and the loop in the red, which is colored red, is the loop of mitral stenosis, which depicts that the left ventricular volume as well as the pressure both will be reduced after as the disease progresses and the severity increases. So in severe mitral stenosis, the LV volume will be reduced and LV pressure is also reduced. Diagnosis, we can establish the diagnosis by proper history taking sore throat and rheumatic fever episodes in the past from the childhood, because latency will be around 20 to 25 years. So the thorough history taking since childhood about the rheumatic fever episodes or the sore throat episodes will help us in the diagnosis. Proper physical examination and investigation can confirm the diagnosis of the patient. In history, symptoms appear gradually over the years. Patient presents with dyspnea on exertion due to lung condition, secondary to increased LA pressure and pulmonary capillary wedge pressure. Patients frequently adapt their level of functional capacity. In later stage, patient may complain of fatigue or weakness due to low cardiac output. Paroxysmal cough, chest discomfort, hemoptysis, and palpitations can be seen. Atrial fibrillation often begins in paroxysmus and eventually becomes chronic. Precipitating factors of marked dyspnea are marked dyspnea is because of the pulmonary edema. There are pregnancy, emotional stress, infections, onset of atrial fibrillation. Embolic events, most of the patients, about 20 to 25% of the patients will present with complaints of embolic events, either cerebral or pulmonary embolism. Abdominal discomfort due to hepatomegaly when RV failure is present. Hoarseness of voice is seen which is also called as Partner syndrome, basically because of the left atrial enlargement. So the left atrial enlargement causes compression in the mediastinum. So the mediastinum, the recurrent laryngeal nerve, which is present in the mediastinum, gets compressed due to the enlarged left atrium. That results in the vocal cord weakness and weakness of the voice. This is called Ortner syndrome. On general examination, we can see mitral phases. The signs we can elicit are severe manifestations of pulmonary hypertension, mitral phases, malar rash over the cheeks, which is bilateral, cyanotic or dusty pink discoloration over and above the upper cheeks due to arteriovenous hypertension, vascular failure. Signs of right heart failure and signs of pulmonary hypertension dominate the examination. These signs in Western countries, we can elicit these marker action and everything. In Indian scenario, it is difficult to identify the stenotic cases because of the dark complexion of our skin. On cardiac examination, low pitch rumbling with diastolic murmur will be heard in the mitral valve area. A typical hollow diastole with decrescendo type with no radiation. A presystolic accentuation in sinus rhythm can be detected when it is of high intensity. An opening snap is heard after the second heart sound. It cannot be appreciated when the valves are calcified. When the valves are calcified, the movement will be severely restricted. So the opening will be very limited and we cannot hear any opening snap. But in mild to moderate disease, we can hear the opening snap after the second heart sound. Interventions: cutaneous mitral puncturectomy or mitral valve balloon valvuloplasty can be done. Valve repair and mitral valve replacement in severe cases. Indications of interventions are moderate to severe mitral stenosis valve area less than 1.5 cm². If the patient is having symptoms with mild area, then also we can perform intervention and can clear the stenosis by mitral valve repair or replacement. In elderly patient, percutaneous mitral puncturectomy is an option when surgery is at high risk. Here comes the anesthesia part. Anesthesia implications of mitral stenosis. If the patient is non-cardiac active, preoperative assessment or detailed history and examination of both general and systemic examination have to be carried out. Assess the functional status based on the NIHAD classification grade 1, 2, 3, and 4. Look for any fibrillating changes in ECG and even in echo. Recognition of compensatory mechanism by maintaining output. Evaluate the patient's hemodynamic state. All the vital parameters have to be monitored in person. In the presence of associated major organ system damage like kidney or liver damage, as well as RVS, right ventricular failure. Drug history and any other common medication, whether the patient is taking or not. If the patient is on anticoagulants, the anticoagulants can be continued for minor surgeries where the blood loss is very minimal to be expected. And if it is a major surgery and we are expecting a major blood loss, then we should withhold the oral anticoagulants 3 to 5 days prior surgery. But for the duration of this 3 to 5 days, we can bridge the anticoagulation with low molecular weight heparin or alternate molecular heparin. We can restart the anticoagulation after the surgery as soon as the bleeding risk is reduced. In emergency surgery, warfarin-induced anticoagulation can be neutralized with FFP and weight movement. And our anesthesia goals are to be very certain, maintain HR on lower normal side. Immediate treatment, we should be prepared to treat AF at any point of the time of the surgery. Adequate compression, maintain adequate preload and afterload, adequate myocardial contractility, reduce the use of fluids. Pre-medication, anxieties are very necessary because anxiety causes hypertension, tachycardia, which precipitate AF and other embolic and thrombotic episodes. So anxiolytics are to be administered for sure. Drugs used for heart rate control to be continued. If the patient is having any beta blockers or heart rate control drugs in the pre-op period, to be continued even during the surgery period. And if the patient is having diuretics to decrease the preload, then the diuretic induced hyperkalemia has to be checked before taking the patient into the surgery or OT. Atropine and glycopyrrolate are to be avoided because they represent AF and thrombotic episodes because of the tachycardia. Opioids, fentanyl, and morphine can be used. In general anesthesia, there is no single particular agent available as of now for inducing, but in moderate to severe disease, the circulation will be very slow. CNS circulation time will be very slow because of the low cardiac output of the left ventricle. So even if you the induction might take few minutes even after injecting the induction agent. For attention, during the laryngoscopy, the heart rate and BP will be very high. So to minimize that, we can use esmolol, lignocaine, dexmedetomidine for rate control. Use volatile anesthetic during the pre-oxygenation period so that the response will be reduced. Intraoperative period, rate and rhythm. If possible, sinus rhythm should be maintained. A low normal heart rate is critical for ventricular filling. If the heart rate is more, then the diastole period of the left ventricle will be less. So, if the ventricle is not having enough amount of time to fill itself, then the output is also reduced. So, if the heart rate is high, the left ventricle diastole time will be reduced. So, the left ventricular filling will be reduced. Left ventricular filling is, if the left ventricular filling is low, then obviously the cardiac output will be low. Preload, aim for normal volume. If we give any fluid, then pulmonary edema might precipitate. So if we encounter any hypertension episodes, then it has to be countered with phenylephrine or phenylephrine so that the volume preload afterload will remain same. Fluid should be judicially to keep the right heart and PA pressure slow. Afterload maintenance is very crucial. Any decrease in afterload is detrimental. Severe hypertension may be seen. Hypoxia, hypercarbia, and acidosis are to be avoided to the possible extent. Nitrous oxide to be avoided in patients with pulmonary artery hypertension because nitrous oxide will cause vasodilatation, which further decreases the afterload, and which further the afterload is low, then again the heart function will be contractility. Aim to maintain adequate myocardial contractility in severe RV failure patients. Augmentation of RV contractility is required. So we can use phosphodiesterase 3 inhibitors, milrinone or dobutamine, so that the left ventricular contraction is increased. Phosphodiesterase can reduce afterload, therefore should be used judiciously. And special concern, marked increase in central blood flow due to overtransfusion, head-down position, intraoperative hypotension. So these can precipitate the disease. So in case of this volume shifts, we have to maintain BP with phenylephrine. So induction, etomidate is the ideal agent as it is mostly hemodynamically stable. Serpentine can also be used. Propofol to be avoided because it might cause hypertension. Even ketamine has to be avoided due to tachycardia, which might further precipitate the AF and thrombotic episodes. Muscle relaxation, provide histamine releasing neuromuscular blocking agents like atropine, ciprofloxacin, naloxone, tanquidine. Steroid group like vecuronium and roperidone can be used for muscle relaxation. Ecmol can be used for rapid suspension anesthesia. Maintenance, the patient has to be maintained with isoflurane. Isoflurane may increase heart rate, so desflurane, sevoflurane can be used. Deep range of anesthesia to be maintained. Goal-directed fluid therapy is key for the management of the case. During minor surgeries, symptomatic patients, we can go for ECG, MIBP, SpO2, and EPO2 monitoring. For major surgeries, invasive BP monitoring, CVP monitoring, pulmonary artery pressure. If invasive BP monitoring CVP is mandatory, pulmonary artery pressure can be monitored in patients with severe LV dysfunction. TE and IABP can also be placed to improve the left ventricular function in IABP, and TE for the changes of central valve or heart disease during intraoperative period. Reversal of anesthesia makes with blood to reduce drug-induced tachycardia, and sugammadex can be used in case of vecuronium and roperidone vaccines. Regional anesthesia, peripheral nerve are very safe and should be used whenever possible. Central nerve anesthesia, subarachnoid block can be performed. Spinal anesthesia can be performed for infraumbilical and lower limb procedures in mild disease. Combined spinal plus epidural anesthesia can be used. Graded epidural anesthesia can be used, and continuous sympathetic administration of local anesthesia can be used also. These things can be done only in mild to moderate. In severe disease, block is contraindicated because it causes sudden loss of sympathetic tone, which results in the sudden fall of BP, and it might further precipitate the condition for undesired outcomes. So the spinal block or spinal anesthesia to be strictly avoided in case of severe mitral stenosis patients. Postoperatively, the risk of pulmonary edema is still there. Risk of right heart failure are still persisting. So the adequate monitoring has to be carried out even in the postoperative period, as they have done in the intraoperative period. So if we are placing an invasive BP monitoring intraoperatively, then it has to be continued even after the surgery in the postoperative period in ICU. Adequate pain management is necessary because even slightest pain might trigger the tachycardia and further precipitate the disease outcome. Elective post-op mechanical ventilation may be required in patients with early dysfunction, and anticoagulation has to be restarted again after the surgery. Thank you for your patience, listening. Thank you, sir.
Any questions in Leva? Good morning.
Good morning,
How
sir.
do you assess severity of mitral stenosis clinically?
Sir, if the patient has symptoms even at rest, then we can guess the patient is in severe mitral stenosis with orthopnea, breathlessness at rest, and on auscultation, any crepitations in the lungs, which pulmonary edema in picture. So we can elicit clinically through these colors.
The gap between the second heart sound and what is, if it is very short, it is more severe.
Okay, sir.
What is critical mitral stenosis?
Critical mitral stenosis is the valve area is less than 0.5 centimeters. Yeah.
Less than 0.8 square centimeter.
0.8, sorry, 0.8. 0.8 square.
How do you manage acute pulmonary edema?
So for maintaining the saturation, we'll place them on NIV, and to relieve the edema, we can administer diuretics or Lasix or Dietol.
Is there any different than Lasix?
Sorry, sir?
Any diuretic preferred than Lasix?
Potassium sparing diuretics, sir. Spironolactone potassium sparing diuretics.
Or torsemide is better.
Torsemide. Dietol. Torsemide.
You did not mention ASO titer.
No, sir, I haven't discussed about AS.
If it's better in which units?
Sorry, sir, your voice is little breaking, sir. I cannot understand.
Todd units. It is normal is less than 300 Todd. Thank you.
Thank you, sir. Thank you.
How do you differentiate curly B lines from curly A lines?
Curly A lines are the transverse lines which can be seen in ultrasound, but the B lines are vertical lines from the intercostal space from the pleura to the base.
Good.
Thanks.
What is the drug of choice for atrial fibrillation?
Sir, amiodarone is the drug of choice.
How do you dose?
So we administer as bolus dose for 152 or 152 to 300 milligrams, and we will continue the infusion of the amiodarone diluted in 50 ml.
For how many hours?
For the next 8 hours.
Infusion is for 24 hours. No?
Infusion is for 24 hours. Sorry, sir.
First will change, but the infusion is for 24 hours.
Yes. Infusion is for 24 hours.
What is pulse deficit? It is the difference
Sorry,
between
sir.
peripheral pulse rate.
Sir.
It is present in AF.
AF, sir, yes. Because heart rate will be around 140, and because of the electrical activity of the atrium, the pulse will be very low because of the ventricular contraction, which contracts independently.
What is carry Combs murmur?
It is a continuous machinery murmur. It's seen
No.
in air.
It is not a machinery murmur. In the early stages of traumatic fever, due to edema of the mitral valves, there will be diastolic murmur. That is called carry Combs.
Okay.
If patient is on digitalis,
Sir.
and how do you treat digitalis toxicity?
Digital toxin. Sorry, sir, I'm not able.
Treatment of digitalis toxicity.
For simple patient, sorry, sir, I'll check it. Sir.
First, to stop the drug.
Hello? Hello, sir? Hello?
Distribute the serum potassium level.
Yes, sir. Serum electrolytes has to be monitored, sir, because of the digital toxin, the potassium levels and magnesium levels will be altered. So we will check the potassium magnesium levels. If there is any alteration, then we'll correct the potassium magnesium levels. So magnesium sulfate and magnesium sulfate can be given in infusions. Along with that, antiarrhythmic drugs can also be administered, sir. Maintained.
Hello.
Hello, good morning, ma'am.
Good morning. What is Valley score?
Sorry, ma'am.
Valley score. What are the parameters we have to say in Valley score?
No idea, ma'am. I have to take it.
So in Valley score, we have to see the leaflet mobility and a valve thickening and subvalvular thickening and valvular calcifications. Okay. So
Okay, ma'am.
each divided into 1, 2, 3, 4. So if Valley score less than 8, you can go for balloon valvotomy. If more than, you can go for mitral valve replacement or repair or something. Okay.
Okay.
And guidelines of non-cardiac surgery.
Non-cardiac surgery. In if the patient is in mild disease and it is a minor procedure, then monitoring of ECG, BP, SpO2, and ETCO2 is sufficient. Ma'am. If the patient is in severe disease or moderate disease, and if he is going for major surgeries, then invasive monitoring is done. If he has thrombotic episodes, then sufficient anticoagulation with short-acting low-molecular heparins can be used.
What is modified NYHA classification?
It has 4 gradings, grade 1, 2, 3, 4. 1 is absolutely normal. There are no symptoms of any shortness of breath even after exertion. 2 is there will be shortness of breath after exercise or exertion, which does not limit his normal activity. And grade 3 is SOB even with mild work that limits his physical activity and household works. Grade 4 is severe shortness of breath even at rest.
In criteria for echo, so what is the diagnosis of mitral valve severity? I mean, mitral stenosis severity, according to mild, moderate, severe, no?
And ma'am, in mild disease, it has three variants, ma'am. Number 1 is mitral valve area. The second one is pressure gradient across the mitral valve, and the third one is pressure half time. Mitral valve area, if it is it is more than 1.5, that is 1.5 to 2.5, then it is mild disease. If it is 1 to 1.5, it is moderate. Then if it is less than 1 centimeter square, it is severe. And if it is less than 0.8, it is critical. And in the pressure gradient, ma'am, if the PHC, pressure half time is, if it is less than 150 milliseconds, then it is mild disease. 150 to 220 is the moderate disease, and if it is more than 220, it is a severe disease now.
What is the predictors of poor outcome after surgical procedure?
Poor outcome.
Age more than 65, presence of CAD, LV dysfunction, severe pulmonary hypertension, RV dysfunction, and associated comorbidity.
Okay.
How can you differentiate cardiac dyspnea and the respiratory dyspnea?
Usually, cardiac dyspnea is associated with the exercise or aggravation of the physical activity. But in pulmonary dyspnea, it is more likely towards the environmental, cold air and other.
Dr. Ravi, please explain about the flow volume loop.
Actually, he is in case now at the moment. In can I explain now?
Explain.
In matrix stenosis, the flow volume loop is the loop which is plotted again as left ventricular pressure and left ventricular volume. On x-axis, we will be having left ventricular volume, and y-axis will be having left ventricular pressure. Usually, ma'am, once again, I will show that. This is the pressure volume loop in matrix stenosis, ma'am. The white area is the normal flow volume loop, and matrix stenosis, the volume will be reduced and the pressure will be reduced. So the red area describes the flow volume loop of the left ventricle in matrix stenosis, ma'am. In case of mitral regurgitation, the volume of the left ventricle increases and pressure decreases. So the loop will be horizontally oval shaped now. In case of
Define chorea and the differential diagnosis of Sydenham's chorea.
Sir, chorea is involuntary purposeless jerky movements of the legs, which is usually because of the basal ganglia, the activity of the inflammation of the basal ganglia due to rheumatic fever and autoimmune antibody antigen reactions in the basal ganglia of the CNS. Sir.
What is DD? Huntington's chorea.
Huntington.
How it is transmitted?
Sorry, sir.
Hereditary, how it is autosomal dominant or recessive?
I'm not very sure, sir.
Autosomal dominant, sir.
Dominant, sir. Thanks.
Which is the best X-ray view to observe for the esophageal compression due to enlarged left atrium.
Yes, sir. And the lateral equidus, sir.
Huh?
Lateral equidus.
Lateral.
So,
View, which view? Right oblique, anterior, posterior. ఏదో correct గుర్తులేదు నాకు. ROA or ROA, I think.
okay, sir. Right. The patient will be okay. Okay, sir. Thank you.
What is P pulmonary?
Sorry, sir. Hello.
P mitral and P pulmonary.
Uh,
In mitral stenosis, P waves are broad and bifield.
yes, sir.
That is called P
Because
mit. In pulmonary hypertension, P waves are peaked. That is called P pulmonary.
in ECG, bifield PVS will be there in middle left atrial and large vessel.
What are the components of jugular venous pulse?
So there are five waves in the JVP, sir.
Yes.
A, C, V, X and Y. A, C, Y, A, C, V are the positive waves and X, Y are the negative waves. Sir.
Tricuspid valve opening coincides with which wave?
Tricuspid opening. C, sir. C wave, sir.
Opening, not closure.
So opening, tricuspid valve opening, negative wave, sir. Y wave, sir.
X descent.
Okay, sir.
What are the complications of atrial fibrillation?
It's a trauma formation because of the underfilled state and stagnation and low flow of the blood in atrial chamber.
Acute lona, chronic lona, thromboembolic phenomenon, common.
Chronic, sir.
Differential diagnosis of thrombus in the atrium.
Thrombus in atrium. Myxoma, sir.
Myxoma, yes.
Sir.
Naveen? Any questions from
మేడం
all?
నవీన్ ఏదో కేస్ స్టార్ట్ చేయాలని చెప్పి ఫోన్ చేస్తాను.
Any questions?
Wind up 9-10. Thank you,
Yeah.
Santosh. Thank you, madam.
Thank you, sir.
Thank you, Santosh. Thank you,
madam.
Naveen. Thank you to all.
Hello, ma'am. Class అయిపోయింది. Dr. Charishma, Dr. Devika, and Vamshi are from. Sir, thank you. Class అయిపోయింది.